All right. Today we're going to talk about the secondary assessment. This is Cherry Fearing, and coming at you again. I just want to spend a little bit of time with you today talking about the secondary assessment, because this is a point in our assessment that we catch those life-threatening things that we didn't catch during the primary assessment. Let me get my mouse going here. All right. This is me, just so you have a face to go with the voice. Little bit about me. I've been a paramedic for about 20 years. I've worked at a pretty aggressive 911 service for about 10 of those years as one of the lead medics. And now I'm the program director at Iowa Western and also a teacher. So I enjoy what I do. I love being a paramedic, and I think what we can do for you guys to get you prepared to go out in the field is going to have an impact way beyond anything that I can do by myself. So let's talk just a little bit about the components of the secondary assessment. Okay, it's going to consist of a physical examination, getting a patient history, and that patient history is going to include history of their present illness, what's going on right now, and then their past medical history. So all of those are going to give us a peek into what's going on into this puzzle that we're working on. And then we want to get a good set of vital signs for a couple of reasons, and we'll talk about those vital signs here in just a minute. Okay, so the secondary assessment happens after the scene survey. So you've got all of that. You've got ALS coming. You've got you made sure the scene is safe. You've got your protection on, all of that good stuff that happens in there. And it comes after the primary survey, which you see here, which basically is getting a general impression of our patient, determining responsiveness, and going through those ABCs, airway, breathing, and circulation, to see if we've got any immediate life threats. If we do, as we talked about earlier, we're going to treat those right then. Okay? But once we have accomplished this, we have treated those life threats that we found, then we're going to move on to the secondary assessment, which is here. Okay, so this is the history taking. That's where we get a sample history. I have taught a lot of classes to nurses and other healthcare providers, and EMS is the only one that uses the acronym SAMPLE and OPQRST. But a lot of people are adopting it, such as the American Heart Association. They have adopted that sample history into their pediatric and advanced cardiac classes because it works so well. So don't get locked into asking those questions just for the sake of covering your steps. Really ask those questions to determine what's going on with your patient. And then you see here we've got the assessment is an actual physical assessment. We're going to look at the head, the neck, the chest. We'll go down and talk about those in just a little bit in detail. And then at the end, we want to get a good set of vital signs and manage any of the issues that we found during the secondary assessment. Okay, so components of our assessment is that sample history. So the S stands for signs and symptoms. Now, a sign is something you can see. I can see if a patient is pale. I can see if they're sweaty. I can see if they're throwing up. Okay, but I cannot see a lot of things, like if they're dizzy or if they're nauseous. Those things are something that the patient has to tell me, and we call those things symptoms. So if you can see it, like you can see a stop sign, that's a sign. If it's something your patient has to tell you, then that is a symptom. And we're going to continue to reassess these as we go through. Okay. Our history taking techniques. So when we start through that sample history, some things we want to keep in mind, okay, is to use our acronyms. You've got that sample for a reason, is to remind you of questions that you need to ask. It is not to limit you only to those questions. Keep that in mind, because oftentimes it's the questions we ask after the sample questions that really dig up the true cause of what we're dealing with. So When asking these questions, always ask open-ended questions. So if you're asking a question that your patient can't answer with yes or no, or you're giving a multiple choice, like if you say, is your chest pain stabbing or sharp or burning? Well, what if it's squeezing and you didn't give them that option? They're going to pick the best option and give that back to you. So if I ask the patient, tell me in your own words, what does this chest pain feel like? I'm going to get a much better description and a bigger picture on what's going on. So those open-ended questions every time you talk to your patient are critical. Okay? And then we're going to use our mnemonics, sample and OPQRST, just to kind of give us a pathway for asking questions. Okay? So when we talk about the physical assessment, okay, we've got some techniques that we're going to use. First of all, we're going to use our eyes and we're going to look. We're going to look for things like skin color and bruising and deformities and swelling and sweatiness, and we're going to look for all of those things. Okay? We're also going to use our ears and auscultate. Okay? So that means sometimes you can walk into a room and hear somebody with difficulty breathing from clear across the room. You can hear them wheezing. We don't need a stethoscope for everything. But we do want to use our stethoscope to pick up those things that we couldn't hear otherwise. So specifically, we want to listen to lung sounds. Okay, it doesn't hurt to take a quick listen to heart tones. We ask our paramedics to do that. But what I tell my paramedic students is you need to listen to lung sounds and heart tones on every single patient you come in contact with. The reason being, we're not very good at listening to heart tones, and we don't hear a lot of things because of the noisy environment that we're in. But if you listen to enough regular lung sounds and regular heart tones, you are absolutely going to recognize when something doesn't sound normal. If you don't listen to normal lung sounds, you'll never recognize it when you hear something abnormal. So auscultate lung sounds or listen to your lung sounds with every single patient. And then on this secondary assessment, we're going to palpate. We're going to use our hands, and we're going to touch everything from the top of their head to the bottom of their feet, because there's going to be things that's going to be picked up when we touch and feel, to be able to see if there's deformities, if there's tenderness. The patient really may not recognize that they hurt in a particular area until we touch it. And once we touch it and push on it a little bit, we might find that there's pain there, which is going to give us a clue that we didn't have before. So we're going to look, and we're going to use our hands. It's not a put your hands lightly on the skin and brush it down. You're actually going to touch. And so you're going to be pushing and testing the structure stability of those arms and legs. You're going to be looking at the abdomen and actually touching it with your hands. Okay. So this is how we're going to do this. Okay, the respiratory system. Probably the most important thing when we're assessing this respiratory system is our patient breathing adequately? And that's our big question. If they are, then we can move on. If they're not, then we need to address that. So if they're having a respiratory condition, we need to find out what medication they're taking, what their condition is, then see if they've taken their medications. Very frequently, you may be taking care of someone with asthma who left their inhaler at home. So that changes things for us. We don't have an inhaler to give them. We know that they need that medication. So that would mean that we probably need to call ALS and get that medication on the way. Okay. We also need to ask our patient if these signs and symptoms are similar to other episodes that they've had. Because just because someone has asthma, for example, doesn't mean they can't get pneumonia. So they may be having difficulty breathing that has absolutely nothing to do with their past medical history. And we want to be able to determine that quickly. So we want to look at their mental status because that's going to give us a peek into how well they're compensating through this event. If our body's able to increase respirations and heart rate enough to keep the brain oxygenated, we'll have a normal mental status. If it's not, we're going to see that mental status start to deteriorate. We're going to see them start with restlessness, anxiousness, and that will kind of deteriorate into maybe they become a little bit slow to respond to you, become a little bit lethargic, all the way down to maybe being completely unresponsive. We also want to determine their level of respiratory distress. Okay, and I think the best way to do this is ask my patient, and that's using that OPQRST. And I ask them on a scale of 0 being no respiratory distress and 10 being the worst kind of respiratory distress you can imagine. How would you rate this? Now we can also look at our patient. Okay, we can look at that work of breathing. If you've got patients using, now I'm talking adult patients when I'm talking here, if they're using their belly muscles to breathe, so they've got that seesaw breathing going on, they're working kind of hard. If you've got a patient that is using intercostal muscles, I encourage you all, when you get done with this, to Google intercostal muscle retractions and look at that. That's something you have to look for. You have to lift up their shirt and you have to look at that rib cage, and you will very easily see, if you're looking for it, those muscles in between the ribs contract and get hard. So they kind of protrude out, and they're contracting, trying to pull that rib cage outward to make a bigger space in the chest to hold more air. So you'll see it if you're looking for it. It's not something that's going to jump out at you if you're not looking for it. We'll also see things like substernal retractions. So those little concave areas in your neck that kind of right by your collarbone, those will suck in when they're trying to inhale. If you're seeing that, that's a work of breathing. Okay? If you're seeing pursed lips, like they're holding their lips kind of in a whistle form and they're kind of trying to breathe through their lips to create a little more force with breathing in and out, that's a sign of respiratory distress. Positioning is a sign. If they're sitting bolt upright and they won't lay down, or they're what we call tripod positioning, we're going to learn about this in a couple chapters with our respiratory emergencies. That's a sign. So we want to look at that chest, look at their work of breathing. How hard are they working to breathe? Other things we want to look at is the chest wall. Is it rising and falling? And if so, is it doing it equally? Or are you getting more chest rise on one side than the other, which would indicate that we've got one lung that isn't working adequately. Okay, so we want to look at that chest wall. If we have a patient that's been injured, we want to look and make sure that we're getting equal rise and fall on both sides of the chest and on all of the chest wall. If we've got some broken rib segments in there, we may see those ribs that are broken loose move differently than the rest of the chest wall. Actually, what happens is they don't move at all and the chest wall moves around them, but it looks like they're moving opposite directions of the rest of the rib cage. So we want to look at that. We also want to listen to our lung sounds like we talked before. When we talked about vital signs, you know where to listen. My favorite place is on the back, right about the bra line, and then under the armpit. So you're listening at the base of the lungs there, and up high on the chest or up above the scapula on the back. And listen carefully on all of those places. This is not a one-time thing. If you've got a patient that has a collapsed lung, that collapsed lung will start small, and you won't be able to hear it when it first starts. You won't be able to recognize that there's not air moving in the base of the lungs. But as that progressively gets worse, you'll be able to recognize it. So I listen to lung sounds 2 or 3 times during my time with the patient just to make sure that things aren't deteriorating. We're also going to use our pulse oximetry. It is not an absolute. It is not a form of examination, but it is definitely something that will confirm what we believe. Now, as we know with pulse oximetry, it measures, most of them measure the gas that's attached to the hemoglobin. Many of them, most of them, cannot determine whether that gas is oxygen or another type of gas such as carbon monoxide. So if you've got some with carbon monoxide poisoning, their pulse oximetry reading is going to read 100%. If we treat our patient based solely on that and completely excuse the fact that they're having difficulty breathing, we are going to make a critical error. Okay? We're also going to look for edema, swelling. And typically the swelling is going to occur at the lowest portion. So if you've got a patient that's in bed, we may see that swelling happening in their posterior, their butt, their lower back. For most people that are up and mobile, we'll see that swelling happen in their feet. And so we want to look at that and simply ask your patient, do your feet seem more swollen than usual? Or you can poke a finger in. And if y'all will poke your finger in your skin, you'll see that your skin bounces back immediately. If you poke your finger into the skin, not hard with your fingernail, but just poke the pad of your finger into the skin, and when you lift it up and indentation remains, then you have fluid in that tissue and you do have swelling. Now as we move farther along, you're going to start to recognize how swelling in the feet is a cardiac problem. And swelling, sometimes we get swelling kind of in the lungs, fluid that backs up in the lungs. It's also a cardiac problem because that respiratory and cardiac system work hand in hand together. The last thing we're going to look for in our physical examination as we go through this is fever. So we want to ask our patient if they've had any chills or if they've had a fever, because you may be taking care of a patient that has had a fever but took Tylenol an hour ago. So their fever is gone, but they've had one, and that's significant because fever represents infection somewhere, almost always. So we want to feel their skin, feel for temperature of their skin. Most of the time in EMS situations, we don't have thermometers on board. If you do, it's okay to take a temperature. If you don't, simply use your hand. Use the back of your hand to feel the temperature of that skin, both on their head and then on their trunk, because sometimes the extremities can be cool, but their chest and back are very, very warm. Okay, so in the heart, we want to think about the blood vessels. Obviously, they need to be the right size. They need to be intact, and they need to not be occluded. So they need to not have clots in them or plaque blockage or anything like that. So a cardiac patient and patients in shock with vascular problems are going to present sick. Okay, so we're looking for those signs of shock. We're looking for a history of heart disease. We're looking for a history of atherosclerosis or something where we've got either plaque building up or hardening of the arteries. Sometimes patients know they have this and they can tell you if we simply ask. We're looking for existing cardiac conditions. We are looking, when we go through that sample history, for medications that would indicate a cardiac problem. So if you've got a patient that has nitroglycerin prescribed to them, you can be almost certain that they have at least some sort of cardiac history. Okay? We want to ask those sample questions to find out what's going on with this patient. Frequently, patients with cardiac issues are nauseous. Sometimes they have chest pain, and frequently they have shortness of breath associated with that. Okay, so find out our signs and symptoms. How are they feeling? Are they feeling dizzy? Are they feeling anxious? Do they feel like their heart's going to jump out of their chest? That's not something we can see, but it's certainly something they can tell us. So we want to get a description of any chest pain if they're having it using OPQRST. Now O stands for onset, and I think we're going to talk about this here just a little bit later. P is provocation, anything that makes it worse. Q is quality. This is where we ask them to describe it to us. We do not describe it to them. R is radiation. Does the pain go anyplace else other than where they have described already? So does it go through to their back? Does it go down an arm? Does it go up into their neck? Anything like that? S is severity. So on a scale of 0 to 10, 0 being no pain, 10 being the worst possible pain they can imagine, how are they going to rate this pain? Now, quite honestly, I've had patients that when you look at them, they don't even look like they're in pain, and then they tell you their pain is a 10. And in my head, and this is totally inappropriate, but in my head, I'm like, well, you're kind of a pansy. But you know what? Everybody has a different pain tolerance, and it doesn't matter what their pain tolerance is because we are consistently going to use them to gauge their pain. So we're always using the same ruler, and we're going to have consistent measurements. So I always tell my patient, I'm going to ask you to rate this pain. You're going to be asked this many, many more times so we can see if we're making any progress with this or not. Kind of give them a heads up. Otherwise, they tend to get irritated when we keep asking the same question over and over and over. But once we do some interventions, we want to check to see if it's working. So we're going to ask them again, what's your pain? And then time is kind of big picture. Number one, when did it start? And has there been other episodes like this? So we want to get the big picture. Okay. And then we want to determine the specific characteristics of this pain. So that's going to be an interview with our patient to find that out. Okay. So looking for signs and symptoms that may be severe, which are things that we're going to see and they're going to tell us. So we want to get a pulse. So we want to know, we want to get the rate, rhythm, and quality. What's the rate? Is it regular? And is it strong or weak? Okay, we need to know those things. Then we're also going to obtain a blood pressure. If you're a little uncertain, it's not ever a bad thing to check a blood pressure in both arms. Okay? If you've got a very distinctly different blood pressure from one arm to another, that is a very significant finding, and you need to communicate that to the hospital or to ALS. Okay? And then we need to know their pulse pressure. How close are the systolic and diastolic pressures? We're also going to look for jugular vein distension. So when we look for JVD, JVD indicates that there is blood backing up when it comes into the heart. So we've got blood coming into the heart, and the heart is not pumping it out as quickly as we're trying to fill it. So that blood will back up into that jugular vein, and we'll see that jugular vein in the neck of the patient start to protrude and stand out. If you see that, then that is pretty indicative of rates of heart failure. And that's going to give a pretty big finger to we've got a cardiac problem with this patient. Okay. We also want to palpate the chest. We want to feel it. So push your hands down the sternum. Put your fingers down the sternum. I know, we women have breasts, and we have to work around those, but you do have to palpate the chest regardless of whether your patient is male or female. So palpate your hand down the sternum. Take your hands on the side of the ribs and kind of push in and see if you've got any tenderness when you're palpating the chest. If you can reproduce this pain by touching or pressing on the chest, less likely that this is cardiac and more likely it's muscular. So we want to palpate the chest, and then we want to look at their posturing and their breathing. How are they sitting? How are they positioning themselves? And make note of that. Okay. Moving on to the neurological assessment. Now, we're obviously going to cater this assessment. If we've got somebody that is complaining of chest pain, we're going to focus our assessment there. Okay. Now, does that mean that we're not going to look at these other things? No, we are going to check the other things, but our focus is going to be on the area of concern, okay, or areas. Okay, so if our patient has a neurological complaint, then first of all, we want to determine their patient's mental status, which we kind of have done earlier during that primary assessment. But if we haven't, what we want to do is start asking those questions. See if they're orientated to person, place, and thing. Do they know who they are? Do they know who other people are around them? Do they know where they are? And do they know a date or perhaps maybe who the president is? They can give you those things, then we're not so concerned about their neurological status. If they can't, that is a primary concern. Okay. We also want to find out, what is their normal mental status? Because if we're asking a patient who the president is, and they normally on the best day of their life don't have a clue who the president is, we're probably getting a false reading here. So we're going to find this out probably from family and bystanders or people that know this patient. And then we want to get a history of any neurological conditions they have. So if I've got a patient that has Down syndrome, I would like to know that, because that's going to change everything. Or if I have a patient that has had a traumatic brain injury and they have some deficit because of that, I want to know that going in so I can measure what's normal and what's not. Then we're also going to note the patient's speech. Okay, is it clear? Is it enunciated? Are they talking in full sentences? Or are they talking in 2 and 3 word syllables? Are they slurring their words? Or maybe their words make absolutely no sense. Okay. There's a very cool video, it's on YouTube now, but news broadcaster was a young blonde gal, and I think you can Google TIA newscaster and she'll pop up. She's a blonde gal. She starts to talk into the mic on national TV, and the words that came out absolutely made no sense whatsoever. And you could see in her face that she's very concerned, and she's trying to say, she's trying to communicate, and she can't. And we call that word soup, and that is typically a sign of a stroke. So we want to look at their speech. Is their speech appropriate? Is it clear? And does it make sense? Okay. Now we want to perform a stroke scale, and as we get to the chapter when we talk about neurological deficits, you're going to learn how to do this. But we do want to perform a stroke scale. There's a couple of stroke scales out there. Probably the most popular is the Cincinnati Pre-Hospital Stroke Scale, which doesn't take very long to do, and it picks up a good number of strokes. There's another one out there that is relatively new. It's called the MEND Stroke Scale. And when we get to strokes, we'll talk about this in depth, but that one is much more extensive, really is pretty quick to do, and will help you recognize a good share of the strokes that occur. We also want to check their peripheral sensation of movement. So peripheral as towards the end of your extremities. So check their radial pulse in their wrist. See if you can find pedal pulses in their feet. Okay. We want to see, can they move their fingers and toes, and can they feel you touching them down there? So generally I squeeze a finger. I have my patients close their eyes. I squeeze a finger and ask them which finger I'm touching, and the same with the toes. Okay. Then I want them to check their strength. So I want to have them grab my fingers with their hands and squeeze as hard as they can. Now I always do this at the same time, because what I'm measuring is the right hand as strong as the left hand? And you can't do that if you do those independently. So stick a couple fingers down in their palm and ask them to squeeze as hard as they can, and see if their strength is equal. On their feet, we want to do the same thing. So we want to put our palms of our hands on the bottom of their feet and ask them to push against your palms. And then switch your hands and put them on the top part of their feet and ask them to pull their feet up into your hands. and see if they can pull their feet into your hands. So again, excuse me, you're checking to make sure that they have good strength and it's equal in all four extremities. Okay. Now, for some patients, we're going to be looking at the endocrine system. Okay, so the most common emergency for this system is our diabetic patient. Okay, so diabetes and or thyroid disease would be something that we'd want to ask some specific questions. Now, when you're asking about medical history, do not say, do you have diabetes or anything like that? I had a student just yesterday ask that question, and the patient said, no, I don't have diabetes. Well, he did have spinal bifida, and he did have an extensive cardiac and respiratory history. But because the student asked, do you have diabetes or anything like that, he answered the question. So the student then went on, assuming that he didn't have any medical history, but there was, and it was the way he asked that question. Again, that was a closed-end question. If he'd have said, do you have any medical history? Do you see a doctor for anything? Have you had any recent surgeries? Or do you take a medication for any medical problem? Then you've got much better information coming back at you. Okay, so we want to look at their medication list, see, number one, if they have something prescribed to them, and B, are they taking it properly? Oftentimes we find patients that have medication, it's prescribed to them, but they really have not taken it on time or regularly, or they've taken too much of it. So we want to find those things out. Okay, with our diabetic patients, it's important that we ask if they've eaten or if they've been doing some extensive exercise, more so than general, because as they're exercising more, say they went out and played a soccer game, they're going to burn up a lot more sugar playing soccer than they would playing a video game. So if that's the case, we would expect them to be have a little lower blood sugar in this case. With that in mind, we also want to ask if they've been sick. So if the body is trying to repair itself, or if there's a fever on board, that patient is also going to use up a lot more sugar for energy because the body's working extra hard trying to recover. So we also want to know if our patient has checked their blood glucose level, and we also want to find out if they have an insulin pump. Insulin pumps are pumps that they generally wear on their hip or somewhere inside their clothing that's got a little cathlon into their skin that measures constantly the blood glucose level, their blood sugar levels. And it administers insulin as needed. So we want to know if they've had that, because that's going to be a measure that's going to help them get through a crisis. Okay. So again, with our endocrine system, we're going to evaluate their mental status, look at their skin. Pale, sweaty skin is a sign that they're in trouble. So look at their skin, check their blood sugar level if your department has that policy in place, and then look for an insulin pump and get that really good history from them. Okay, our gastrointestinal system basically is your digestive tract. So what we're looking for is what's going in and what's coming out. Okay, so if our patient is not eating or drinking, that's going to cause problems in our digestive tract, particularly if they're not drinking anything. It can cause, especially in our elderly patients, bowel obstructions. If they're not eating a lot of fiber, we can have bowel obstructions, constipation, which kind of seems like a frivolous thing until you've had it. And bowel obstruction can be life-threatening. So we also want to see what's coming out. So if they have diarrhea, we want to find out what is it like. Is it watery? Is it mucousy? Is it bloody? We want to ask their questions about their stools. If they're black, tarry stools, very black and thick and dark, or maybe even not thick, but dark black, dark brown, dark red, we need to know that. That's a sign of internal bleeding. We also want to know if they're bleeding, is it dark red or bright red? And that will help us determine what's going on. And we're going to talk about all these systems in depth as we move forward, but we're just kind of looking at how we put the questions in place for this assessment right now. Okay. So if they are vomiting, we want to know what that looks like. If it looks like coffee ground emesis or coffee ground vomit, like their vomit has coffee grounds in it, that's a sign that they're bleeding into their belly. So we need to know that. Blood in the tummy almost always makes you throw up. So if they've got a bleeding ulcer or bleeding in the esophagus somewhere that's going to go down into their stomach, they're probably going to vomit that back up. So we want to know if they're having any pain with all of this. Okay, and we also want to ask that infamous question, when did you have your last bowel movement and was it normal? To kind of get a good idea on what's going on here. Internal bleeding can be life-threatening, so recognizing that is easy. There is a smell about a GI bleed, so if it's bleeding in the intestinal tract, there is a very distinct smell. I can't explain it to you, but one time you smell it, you will know what I'm talking about, and you will always recognize it from that point on. Okay. So look at the positioning of our patient. Oftentimes these patients are kind of curled up if they're having pain. They will draw their knees up to their chest and kind of be in that fetal position to relieve some of that pain. We also want to assess the abdomen on this. This does not if they're having belly pain, it could be a lot of things. It could definitely be something with their GI tract, but it could be so much more. It could be an infection in and around there. It could be a perforated bowel. It could be appendicitis. It could be 100 different things in their abdomen. So we want to assess the abdomen. Okay, and one thing we want to do is take the full flat part of your hand, and we're going to divide that abdomen into 4 quadrants. Okay, we're going to have one line running from side to side, right straight through their belly button, and we're going to have another line running up and down right through the middle part of their body, again through their belly button. And then we're going to have those quadrants. So we're going to have the upper right and left quadrant, and we're going to have the lower right and left quadrant. And again, those are the patient's right and left, not ours. So you're going to take the flat side of your hand and palpate each of those abdomens, which means to feel. So I basically lay the heel of my hand on the outside edge of the abdomen, and I roll it across the abdomen roll my whole hand pressing down. What I'm feeling for is if there is any rigidness, if there's any swelling, if I'm feeling a pulsating mass in there, which is going to indicate that our aorta has an aneurysm, is bulging. So I'm looking for those things. I'm also watching my patient's face when I do that. I want to know if there's any pain or tenderness or any guarding. If they reach over and push your hand away, then we know that there's pain there. Okay. Now that being said, if the patient tells you that they're having pain in their left lower quadrant, then palpate that gently and do it last. I mean, if we know it hurts, there's really not much sense in us poking on it, but we do want to find out if it's rigid or not. Okay, but do that last. Go to the other ones first. Okay, we're also going to look at the abdomen and see, is it normal, or does one side of it bigger than the other? Okay, does it look swollen? Does it look distended? So we're going to look at other parts of the gastrointestinal system, and a lot of that we're going to ask. Some things like hemorrhoids we could be able to visualize specifically, but the rest of it's kind of inside. We're not going to be able to really inspect and look at a lot of that. Okay, but if vomitus or feces is there, we may want to look at it. There's some school of thought that if it's remarkable or there's something in it, you may want to take it with you to the hospital. They can check for blood in both vomit and feces, so it might be of some value to take some of that with you if it's available to do that. Okay, our immune system, which we all should have, and that's our white blood cells in our body for the most part that take care of that immune system. But we want to find out, what's their history? What allergies do they have? If they have an allergy to shellfish and they have just been at a Thai restaurant having a noodle dish, perhaps there was shellfish in there and we need to deal about that. Absolutely, the biggest problem that we want to worry about in this case is anaphylactic shock. And that's when a patient has a severe allergic reaction to a substance and their airway swells shut. So this may be something we want to ask some very quick, precise questions about to find out what we're dealing with. Okay. So if they have an allergy, what's their typical response to that? Okay. We want to find out those signs and symptoms right away. If they are in anaphylactic shock, that airway can swell shut in a matter of very few short minutes, and then we no longer have a patient. So this is kind of emergent. So if they're telling you that they feel tightness in their chest or their throat or their tongue, or they're having difficulty talking, quickly look in their mouth. If their tongue is big and fat, you have anaphylaxis and we need to act on that. Look at the uvula, or that little hanging down thing in the back of the throat. If it's short and stubby, you're probably dealing with an anaphylactic reaction. And then ask them if they have a medication. Many people that have this severe allergy have an EpiPen. So we want to find out, do they have one and where is it? And get that squared away. So look at that, inspect, ask questions about what they've come in contact with. We can look at their skin for hives. Oftentimes these patients will develop hives. If they have a very severe reaction, the airway swelling may occur before the hives develop. So if they don't have hives, don't let that throw you off that this is not an allergic reaction, because it could be. Look at their face, their lips, their mouth like we talked about, and see if you see any swelling there, and listen to their lungs. Okay. Our musculoskeletal system is our muscles and our bones. The medical process for this is diseases in the bone are fairly rare. You may have some issues where you have children with a disease called osteogenesis imperfecta, which is very, very brittle bones. And these patients will have maybe even hundreds of fractures throughout their lives. With patients that are really bad, if you just grab a hold of their arm to move them out of the way, or grab a hold of their arm to tug them along with you, you would fracture their arm. So you have some of those rare things out there, but not something we come in contact with hardly ever. So what we do want to look at their bones, ask those questions about the medical history, and just run your hand down and check the structural integrity of the bone. Now you can't do that by sliding your hand down their arms. You're going to have to do a little bit of, kind of twisting, tugging back and forth to see if those bones remain intact and see if they hurt. Okay, asking about prior injuries. A couple things that would be of concern in the musculoskeletal system is if they're taking any blood thinning medication. If they are, and they've got any internal bleeding from tears or fractures, this could be a major concern. So particularly, I think the most common time for this to ask would be a patient that has fallen and had a hip fracture. If they fractured their hip and they're taking blood thinning medications for any other reason, this could be a problem. Okay. So we're going to inspect for signs of injury. So we're looking for deformities that could have happened in a traumatic situation or in a medical situation. If you've got a medical condition that would cause them to be deformed, we need to know what their baseline is, obviously. So we're looking for deformities that are unusual to them. We want to palpate areas that have a suspected injury unless it's very obviously fractured. If you're not sure, palpate, but start gently. If it looks like it's going to hurt, don't just grab a hold of it and start yanking it around. Okay, and then look at, if you're not sure if a hip looks weird or not, look at the other side and use that to measure. It's kind of nice that we have symmetrical sides, so you can use the unaffected side to help you assess the affected side. Okay. Crepitation is bone against bone. It's that crunchiness when bone scrapes against bone, and we have that when we have a fractured bone. So if you're palpating the chest wall and you go down and you feel that kind of crunchiness under your hand, that is bony crepitus, and that very often times indicates a fracture. Okay. So we need to assess our patient, as we said, head to toe. And this is very important when we come across injuries like this, particularly if, well, actually with every patient we need to, but with children, absolutely, because we may be the one thing that picks up on abuse. Also with dependent adults, we need to do that. But there's also cases of domestic abuse, all types of situations where we could find injuries that they're really not willing to report, or old injuries that have gone unreported or untreated. Okay, or if your patient's unresponsive and you don't know why, head to toe. You got to find out the reason. Start at the top of their head because that's the most important, and you're going to go all the way to the bottom of their feet, check down the head, the chest, the torso, the back. I go down both legs, then I come back up and do the arms. And I do that systematically every time so I don't forget something. Okay, so on our medical patient, we're going to focus on their chief complaint. Okay, if they're unresponsive, then we're going to look at physical findings. So we're going to check those ABCs first in our primary assessment. And if we don't find anything, we're going to start at the top and go down. We want to find out from bystanders and family members all the information we can find out, because when we leave with our patient, we're leaving those people behind, and that is our only source of information. So start asking those questions very quickly. We're going to take a good history of the present illness. We want to get a good past medical history. Again, open-ended questions. We want to perform that physical exam. Okay? So we're starting at the top of their head and going all the way to the feet, and we're getting a set of vital signs. Now, the vital signs on your National Registry sheet are listed towards the bottom of the secondary assessment. That does not mean you can't get them early. If you've got a partner there, have them take a set of vital signs and get them done early. We're going to use those vital signs as our baseline, and then we're going to trend those vital signs. And I think you probably discussed this in your vital signs chapter. But we're going to use those to trend. The quicker we get it, the quicker we can start the trending. So get a good set of vital signs. Treat anything that you need to treat, and transport our patient based on the findings that we have. If you find something that is life-threatening, then that transport decision needs to be made very early. You can do this secondary assessment in the squad, and that's probably where it should be done a good share of the time. Okay. So we want to get a history from our patient, if we can, bystanders and family, and ask those open-ended questions. Okay. So first thing is we got to find out the chief complaint. And basically when I walk in, I introduce myself and I ask, why'd you call us here today? And they're going to give me their chief complaint, hopefully. Okay. Now, sometimes what they call you for is not really what their worst problem is, but it's a good starting point. And as you work through your sample history, you're going to find out a little more information. Okay. So we're going to start with OPQRST. Okay. So based on their chief complaint. Now, I want to preface this by saying it's on your National Registry sheet. You need to recognize that this is a set of questions that you should ask under certain conditions. If your patient is having no discomfort and no pain, these are difficult to ask because they don't pertain to them. But if they're having any discomfort or pain, then we want to start asking, what were you doing when this pain started? Okay, what was going on? And that's the O, onset. P is provocation. Okay, does anything make this worse? And I like to tag on another term called palliation, and that does anything you do make it better. So if they're having really bad chest pain and getting up and moving around makes it worse, then does sitting quietly make it better? Or does breathing slowly make it better? Or does holding your ribs cage make it better? I mean, there's a lot of things that could play into this. So ask those open-ended questions. Does anything make it better, or does anything make it worse? Okay. Quality, we talked about this. That's when the patient's going to describe to you in their own words how this feels. Okay. I'm not really liking this at all. The R typically stands for radiation. Okay. This particular textbook uses region. So I just want to know, does it go anyplace else? Okay. Where is it, and does it radiate? Does it go anyplace else, any other region other than what we're talking about right here? Okay. Severity, how bad is the pain on a scale of 0 to 10? If we use the term 1 to 10, which is frequently used, it may even be mentioned in your book. If it's 1 to 10, we're indicating that there is a level of pain. I would like to give my patient the option to say, I have no pain, because with my interventions, that's what I'm hoping to come to, that they don't have any pain. So I would like to give them, how bad is the pain on a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain you can imagine. For people that have had kidney stones, that's typically what they kind of can relate to as a 10 pain. For women who have had childbirth without an epidural, that typically is their 10 pain. And then time is, when did it start? We'd like to know when this started. And I like to ask big questions. Okay, so this started 20 minutes ago. Has it happened before? And if your patient's like, well, yeah, it started about 20 minutes ago, but I had a little bit of it yesterday. Okay, so that makes it a bigger picture. That yesterday I had this episode too. So this isn't isolated to just this 20 minutes. It's happened in the past. Okay, and then we move on to our sample history. And you guys are going to use these over and over and over. So learn them and get to know them. Okay, S is for signs and symptoms. Okay, we can see the signs. What we want to find out from our patient is the symptoms. Okay, what are they feeling that I can't see? Okay, allergies. Do they have any allergies, both to medications, to environmental things, and to food? I want to know. And I would like to know what their reaction is. A lot of patients are like, well, yeah, I'm allergic to penicillin. Well, what happens when you take penicillin? Well, it makes me feel kind of nauseous. Okay, I'm not really worried about that allergy. If they take penicillin and their airway swells shut, I'm pretty worried about that one. Okay, so find out the allergies. M is for medications. What medications do you take? So what I'm looking for is medications that are prescribed to them, over-the-counter medications that they may have taken, also herbal medications that they take, because a lot of herbal medications, although there's some good benefit, they interact with prescription meds, and they have an effect on our body that we need to know about. Okay. The other thing with medications is I always ask, particularly with my chest pain patients and my females. With females, I want to ask if they're taking birth control, because in some situations that can be a huge consideration, especially with blood clots in women. The other thing I want to ask is if they're taking any erectile dysfunction drugs. Typically, people, both men and women, take those things, and they don't take them always. It's not like something they take every day. And they also don't feel like it's really in your business. It doesn't really have anything to do with chest pain. So they're not going to bring that up because it's, somewhat embarrassing. So ask about those things. Then ask about their pertinent past history. For the most part, I really don't care if they had their tonsils out when they were 4. I want to know, what are you dealing with now? So I ask them, do you have any medical issues? I just leave it open. And then if they tell me yes or no, then I go into, do you see a doctor for anything? If so, what is it? Have you had any recent surgeries? If so, what are they? And do you see a doctor regularly for anything? Okay, or within the last year for anything. Okay, then last oral intake, I need to know what they've eaten and what they've had to drink. Okay, whether that's, are they drinking enough to stay hydrated, or how many alcoholic drinks have you had today? Okay, I need to know that last oral intake. And then I need to know what was happening when this started. If I've got a chest pain patient that developed chest pain and he tells me it's an 8 on the scale of 0 to 10, and he was sitting in his recliner when it started, I am much more concerned than I am about a gentleman who was out loading wood in his truck for the past 2 hours and developed chest pain. Simply because if you're exerting yourself, you're using up oxygen and causing a great deal of strain on your heart. Where if you're sitting very still and that chest pain starts, your heart is going to be probably a little more volatile. So let's see. Remember these, use these, and don't forget to ask your OPQRST and your sample questions. Okay, so we're going to tailor this to our chief's complaint. We're going to ask questions about the chief complaint, and we're going to focus our very thorough assessment on that body system that is identified with that chief complaint and with our other findings. Okay. Now, with our kiddos, we got to get on the same level as our kids. So don't use medical terms with your patient unless you know your patient's a medical provider and understands them. Okay? Use simple terms. I'm going to listen to your lungs. I'm going to check your pulse. Okay? And with kids, typically, can I listen to your heart? And even if you're listening to lungs, they don't know what lungs are, but they know they have a heart in them. So get information from your caregivers, but don't forget to talk to your kid. Okay? When I come in with kids, first of all, I like to make some communication before I ever approach. I don't want them to be afraid of me coming up because A, number one, I'm a stranger. B, number two, I'm dressed differently. And B, number three, I'm doing things that people don't normally do to them. People don't normally come over and start touching all over them. So, and they don't typically drive up in a big truck with lights and sirens on it. So get on the same level as your kiddo. Always be at their eye level or lower. And that way they feel like they can trust you. If you lord over them and you talk above them, you're not going to gain their trust, and that's going to make your assessment very difficult. Okay? So we're briefly going to examine the areas of concern based on our chief complaint. We talked about a lot of those already. We're going to auscultate and listen for lung sounds more than once. Okay? And then we're going to get that good set of vital signs. So we're going to get that set of vital signs, and we're going to trend them, depending on our patient, every 5 minutes for an unstable patient, every 15 minutes at least for a stable patient. And they compare. If we see a trend, if we see their heart rate going up, then we know that their body is getting to be or is trying to compensate more and more. If we see blood pressure going down, then A, we're either doing well and bringing the pressure down where it should be, or our patient is deteriorating if our blood pressure is going down in a negative way, going down to the low side. So our decision for transportation has to be done early. Okay, so it's basically done right after that primary assessment, but we're going to reevaluate that during the secondary assessment. If we decided this patient isn't all that sick, and once we do this secondary assessment, we're finding some things that make us go, then bump that transportation decision up. Get them in the back of the squad. You can do the rest of this en route. There's nothing magical about staying on scene to do this secondary assessment. Just get your lung sounds before you leave so that you can hear them well, and you can do the rest of this in route to the hospital. Okay, so unresponsive patients. We're going to begin with a physical exam because we can't ask those questions. We can't get a chief complaint, so we want to get a physical exam. If they're unresponsive, I take the clothes off a lot of the time. It helps me to understand whether it's medical or trauma. Look at them and get a good set of vital signs right away. If you can get history from somebody that's around, do that. But this is a very quick head to toe, up and down, looking at the entire body. We're looking for all of that DCAP BTLS. D stands for deformities. C is contusions. A is abrasions. P is punctures. B is burns. T is tenderness. L is lacerations. And S is swelling. So we're looking for anything that is abnormal as we go down through there. Okay. So head to toe, we're assessing the head. Okay. So on the head, we're looking for any deformities, soft spots. We're checking the back of the head, the skull, the face, the facial bones, the forehead. We're looking at the ears to see if there's any fluid leaking out of the ears. We're checking behind the ears for signs of bruising. We're looking around the eyes. We're looking at the nose and mouth to see if there's any blood or fluid leaking from the nose and mouth. We're going down the neck. We're checking for integrity in the spine. We're checking for JVD, that jugular venous distension. We're looking at the trachea to make sure it's in the middle of the throat. If a trachea is off to one side, we call that tracheal deviation. That is a very, very bad sign that we've got a tension pneumothorax in the chest. We're assessing the chest. So we're looking for all of those things that DCAP, BTLS, deformities, contusions, abrasions, punctures, burns. Tenderness is going to be difficult on an unresponsive patient, but lacerations and swelling. And we're looking for all that as we go down through and palpate. We're checking the integrity of the chest wall. Okay. We're going to check their abdomen, again, like we said, feeling all four quadrants to see if we have any puncture wounds or tenderness or guarding, rigidity. We're going to check the pelvis. We're going to push down on the sides of the pelvis, and we're going to wrap our hands around the pelvis and try and pull it together to make sure that that pelvis is intact and not broken. So it should be stable. It should not move. If it does move, then we probably have a fractured pelvis. We're going to look at all the extremities. Again, going down through checking for all of those things, checking for the integrity of the structural system. We're checking for pulses in the extremities. And then we're going to check the back. When we roll them on the backboard of the cot, we want to run our hand down and check down the spine, down the buttocks, and check and make sure that we don't have anything that is substantial there. So it's a very quick head to toe. Okay. And we're going to go through this again because I just went through all this. We're looking for JVD, medical identification necklaces around the neck. We're looking for breath sounds at the chest. We're looking for firmness and rigidity in the abdomen. Okay, in the pelvic area, as well as checking for stability, we're also going to check to see if they've been incontinent of either urine or if they've lost control of their bowels. Typically, that is pretty common in a seizure patient. Another thing that we're going to check for there, and you're going to learn more about this in your trauma situation, but in a male patient, we're looking for an erection. An erection in a male patient is signs of a very serious neurological injury. So if you see that in an unresponsive patient, that's not normal, and we want to make note of it because that's a very significant finding. Okay. Extremities, we're looking for pulses. If the patient can move and tell us if they can feel, we want to check that. We want to check O2 sats if we have not done so already. Okay. Again, we're looking for bracelets to see if they have any medical identification. Okay. And then we're going to check the pupils because that's the window into our brain. So look at those pupils and see how they're reacting. Okay. We're going to check all of those things. Skin being a vital sign all of its own. I'm sure we've talked about that in the vital sign chapter, but take a quick look at the skin. It's your first indication that your patient is going into shock. We'll talk about shock as we get a little further in. But any abnormalities need to be noted and passed on to the care providers you're going to be delivering to. Okay. Get a good set of vital signs. Think about calling ALS. Okay. And depending on what that be, it may be a helicopter based on where you're located. It may be a tier with somebody. It may be that you're having ALS come to your location, depending on what you've got. So make that plan early and get them started quickly. Okay, we're going to get a good history from bystanders on our unresponsive patient. We want to do this quickly because, as I said, we're going to leave them on the scene when we leave. So, did the patient have any complaint before he went unresponsive? Does anybody know if he has any illnesses? Does anybody know his name? Does anybody know what happened? So we're looking for indications of spinal injury. If so, then we want to immobilize that patient, put a C-collar on, put them on a long spine board, and move them. If you don't find any of those indications and it doesn't appear to be trauma, we may still use the long spine board just to simply lift the patient, but you don't necessarily need to keep him on there if you don't have to. Okay, so we need to make that quick decision on what type of secondary assessment we're going to do, responsive or unresponsive. We talked about both of those. Okay. We're going to get a good history. We're going to get a past medical history and do that quick physical exam and then jump on our vital signs. Okay. Since unresponsive medical patients can't communicate, then obviously we're going to have to do it all ourselves, do it with the physical and get the history as best we can from the bystanders. Okay. We may or may not change our treatment plan based on our history, but the purpose is to find things that we missed into the primary assessment and treat them, address them, or at least bring them to the attention of the emergency staff that will be delivering this patient to. Okay, we're going to pause there. We're going to come right back and do the secondary assessment of the trauma patient in just a few minutes. So I appreciate your time and attention, and we will visit with you again very shortly.